Hi, this is Alan Gardner, Senior Lecturer in Advanced Clinical Practice at the University of Central Lancashire. And thank you for listening to this first in a two-part video series on epidemiology. As you can see, this one is about the principles of epidemiology. This is going to include understanding what we mean by epidemiology, so what is it as a specialty or discipline, and being able to recognise how epidemiology actually affects healthcare on the whole. We can see on this slide then that epidemiology comes from three words. They are actually three Greek words. Epi meaning something that is upon something else, something that is on it, or something that falls upon it. Demo meaning people or population, and then logos being the study of those things. So epidemiology literally means it's a portmanteau, that being a joining together of those three words to become the study of anything that happens to people, or in brackets here, that which befalls man. Now that's or should we say that which befalls people, because obviously we want to include all people in that. It's not just about males, so that could actually be quite misleading there. So it's the study of the occurrence of illness. But that's so actually we need to kind of caveat that, because when we think about illness, or we'll refer to disease, so within epidemiology they tend to sort of use the word disease as a bit of an umbrella term to capture everything, but actually that doesn't just mean communicable diseases. That's part of it, and I think if you're listening to this, I'm recording this in 2020. We're right in the middle of the COVID-19 pandemic. So I think that probably lots of people have heard the term epidemiology and probably automatically assign that to the idea of communicable diseases. But epidemiology is also concerned with non-communicable diseases. This could be anything that befalls people. So that could include road traffic accidents, diabetes, other diseases that develop within the human body or within populations, such as cardiovascular disease, that it's not due to an exterior pathogen like a virus or bacteria, but epidemiology is concerned with the study of this so that we can understand it and therefore alleviate some of the suffering as a result. We'll see in the coming slides that actually epidemiology originated from the study of communicable diseases, but it has branched out to incorporate all the other things that can possibly befall people, as I said, from cardiovascular disease through to occupational risk factors and occupational-based health problems, including communicable diseases as well. Here we have two contemporary definitions of epidemiology, trying to explain exactly what it is. Obviously the first one on the left is more concise. This one comes from the National Institute of Health and Care Excellence, which just simply says that it's the study of the causes, distribution, control and prevention of disease. Okay, so that means that epidemiology is concerned with studying what actually causes disease. So I guess I've already alluded to this by saying that some diseases are caused by communicable pathogens, such as the virus that causes COVID-19, or there's bacterial illnesses. But then there's other underlying causes that can contribute to the development of disease as well. So again, I've already alluded to cardiovascular disease, which we know is potentially caused by smoking and other lifestyle factors, such as eating a diet that's rich in fats, or at least calorie dense foods that encourage people to become obese. So we know that obesity can increase people's risk of developing cardiovascular disease. And we know this as a result of the field of epidemiology in part. So epidemiology is concerned with identifying who's at risk of a certain illness and what the potential causes might be. Also looks at the distribution. So it's about looking at anything from small groups of people, so that might be as small as a couple of individuals, such as a household, all the way through to larger localized populations, so villages and towns, through to sort of regional distributions. That might look at a particular area, such as I'm in the UK, so that might include a county. And again, we're seeing sort of live versions of that at the moment. We've just left the regional lockdown structure. Actually, we leave that tomorrow at midnight for COVID-19, where we have this tracking of distribution of disease within particular regions, and we've seen this tiered system where we have 3 tiers of public health measures based on particular regions. So that's looking at the distribution of COVID-19 within sort of regional counties and putting public health measures in place as a response to that. The World Health Organization at the moment is obviously looking at a bigger picture, so that's looking more globally. So epidemiology thinks about or considers how disease presents itself within subsets of people. So from, as I said before, from kind of small subsets all the way through sort of looking at like regional and then countrywide and then even globally or sets of countries. And it considers how to control that. So the kind of the underlying principle of epidemiology then is understanding where disease comes from and how it presents itself, but also what can we do about that. So once a disease is within a population, how can we improve the health of those people? So for example, with diabetes, we know that there are groups of people who already have a diagnosis of diabetes or other chronic illnesses. So how can we actually control that by increasing the care for those people, or improving the care for those people, while decreasing the likelihood that new people develop that disease? That includes prevention. And we see this in sort of everyday situations where we see public health messages on TV to promote healthy eating in children or healthy eating and exercise in families. And this comes from this understanding that we have of health that's developed through epidemiology. Then we've got this longer definition from the BMJ that epidemiology is the study of how often diseases occur in different groups of people and why. So epidemiological information is used to plan and evaluate strategies to prevent illness and as a guide to the management of patients in whom disease has already developed. So this is kind of embellishing the nice definition that we've already seen there, and this kind of reasserts the information that I've just been discussing, this idea that epidemiological information is used to actually plan and evaluate strategies. So this is considering how does science actually interface with not only public health measures, but also, again, we're seeing live versions of that at the moment as to how epidemiology can interface with government. So that's what we mean by strategy. So placing kind of overarching principles that aim to control disease within certain populations. We see that in other ways, that we have an increased amount of tax on sugary foods within the UK. So drinks containing high proportions of sugar will cost more, or at least you're taxed more on them than low sugar alternatives. We've also seen other public health initiatives based on epidemiology, such as the move to ban smoking in public places. That was put in place by the European Union all the way across its member countries, and that has seen a decrease in the uptake of smoking and an increase in people's health from smoking-related disease as a result. Now we get to this idea that epidemiology is the study of several things, some of which we've already discussed as part of the definition, but one of them that we haven't really touched on is this idea of determinants. I guess I've alluded to those slightly because I'm saying that there's, I mentioned this idea of lifestyle risk factors, and that's what we refer to as a determinant of health. Determinants are factors that might influence someone's health. Now, we can see those in two main categories. We can see them as modifiable determinants of health and non-modifiable determinants of health. So I've mentioned a couple of the modifiable ones. So these are things that people have some element of control over, or at least we kind of categorize them in that way, and even though actually it might be controversial. So for example, with smoking, we see smoking as something that people can modify. So we know that it's possible for smokers to give up smoking, even though that's extremely difficult. So that is technically a modifiable risk factor. However, we've also got to recognise that there's other factors at play that make it very difficult for people to make those sort of very big changes in their life, and that is how long they've smoked for, how many cigarettes they smoke on each particular day, which is an indicator of the extent to which they are addicted to nicotine. Also, I guess the sort of socio-economic pressures on people to continue smoking. For example, we've seen peer pressure in certain groups. Also, your socio-economic status might impact on whether or not it's possible to give up smoking, or at least how difficult it's going to be. Other modifiable determinants of health might include diet, so you're able to change the things that you eat to an extent, or at least with the right level of support and health promotion, people are able to change the way that they eat. So you might see your weight or your BMI as a modifiable determinant of health, because people can manipulate their weight based on the food that they eat and the exercise that they take, or the amount of calories they burn throughout the day. Non-modifiable determinants of health will include things like ethnicity. So you're unable to change your ethnicity, you're unable to change your gender, so they are not modifiable determinants. But these are still factors that will have an impact on whether or not you are likely to develop certain diseases. For example, we know that cardiovascular disease is you're more likely to develop it if you are male compared to being female. However, there are other diseases that are more likely to manifest in women, for example, osteoporosis. Another sort of example of this that we can see live around us at the moment is the fact that black and minority ethnic groups seem to be being more strongly affected by the COVID-19 disease. This is another sort of live example of how we still don't know exactly why that is. I think currently it's believed that it's unlikely to be due to sort of true genetic factors and more likely to be sort of multifactorial. So, for example, we may have some socioeconomic factors that explain why people of black and minority ethnic groups are more likely to be affected by COVID-19, and that might be that the socioeconomic factors contribute to the development of other underlying health issues. For example, if you are from a poor socioeconomic background, then you are more likely to develop diabetes and more likely to develop heart disease, and we know that this sort of what we call comorbidity increases the likelihood of having a more severe response to COVID-19. Moving on from determinants, I've already mentioned the idea of distribution, and we've kind of alluded to this idea of occurrence. So occurrence is tracking, how frequently does a certain event or disease manifest within a population. I've already mentioned the idea of controls, and we're getting this idea of patterns as well. So epidemiology looks for how disease kind of manifests itself in particular patterns. So, for example, with communicable diseases, they're referred to as clusters. So we might see some like clusters being small groups or potentially large groups of an outbreak of a disease. But we might see that with non-communicable diseases as well. So, for example, I've already mentioned how we see patterns of disease developing in areas of low socioeconomic standing. Taking a step or two back from 2020, then we can see that epidemiology as a field of study originated in the early to mid 19th century. And this is thanks to this gentleman, John Snow, who was a physician living in London at the time. He's regarded as the father of epidemiology, and he was responsible for this careful mapping of cholera cases in East London during the 1854 cholera epidemic. So he was able to study various cases of cholera, and by tracking these clusters, I've just mentioned this idea of clusters, so where was cholera sort of popping up most frequently, and he literally drew them on a map, and we'll see that on the next slide, and he was able to trace the source of an outbreak of cholera to a specific water pump. So this is obviously back in the 19th century, when sanitation was much different to how it is these days in the UK. So people get their water from hand water pumps, and within London they were the water was provided by several water companies responsible for cleaning and sanitizing the water, and because cholera is a waterborne bacteria that causes diarrhea and gastrointestinal symptoms and potentially death within a few hours of the onset of symptoms, it was imperative that someone was able to identify what was causing that. Now, that's obviously the 21st century perspective on cholera. What was particularly groundbreaking for John Snow at the time is that there wasn't a pathogen-based model of disease at the time. His work actually helped to underpin new perspectives on disease. Now, at the time, it was thought that disease came from what was referred to as miasmas, which were these sort of strange ethereal smells, essentially. So people close the windows on an evening to stop bad smells from coming into the house, for example. And so people thought that these bad smells brought with them disease. But obviously that we now know that that's not true. And that, with cholera in particular, as I said, it's a waterborne bacteria. So as we move on to the next slide, we can now see, so on this top right hand map here, and this is a very simplified map of the area of London where John Snow was able to track this cluster of cholera from houses that were accessing the water pump on Broad Street. And he specifically investigated where these households were getting their water from. So he kind of embodies this idea of epidemiologists as detectives. So they're kind of scientific detectives whose job it is to identify new diseases and to identify where areas that didn't previously suffer from a disease or from illness, if they now do. So you've got like a new outbreak of a disease or a new occurrence of illness. It's the epidemiologist's job to track that down and to investigate, why is this happening and what might be causing it and what can be done about it. We'll get more into that shortly. But again, we can just kind of see on the left of the screen here why John Snow's work at the time was so groundbreaking, because he didn't stop with his map. He actually counted the number of houses that were getting water from this particular water supply, the Southwark and Vauxhall Company, and how many deaths there were from cholera. And then he went even one further by tracking that in terms of deaths per 10,000 houses. Because if we were to ignore this column on the right-hand side and just look at deaths from cholera, so we can see that there was a significant number of deaths from the Southwark and Vauxhall Company, and when we compare that to the Lambeth Company, that seems much larger. But if we look at the other districts in London on the whole, that there's a larger number. So actually what we need to do is track the proportion of deaths. So that's what he's doing by looking at the deaths per 10,000 houses, and that then demonstrates how there's a disproportionate number of deaths coming from the Southwark and Vauxhall Company. That we can see that 315 is significantly higher than the 56 per 10,000 houses for the rest of London. So this was groundbreaking work at the time. As I said before, this kind of laid the foundation for what we know about epidemiology as a study now. Epidemiology then is the science behind public health. That we can understand public health as the means to which we can improve the health of large populations of people. Public health initiatives tend to aim for the maximum impact on the largest number of people, and these can be very simple yet very effective measures. So, for example, hand washing. That's probably the single most cost-effective public health measure that we found so far. I've already mentioned before the idea of the smoking ban. Now, that was controversial to some people, mainly smokers, I think, who they see that as, or potentially some smokers might see that as a deprivation of their liberty. That if they choose to smoke, why should that choice be taken away from them? But in terms of public health, we know that passive smoking has an impact on those around you who don't choose to smoke. So if you're allowed to sit in a restaurant and smoke a cigarette, the people around you who don't have the habit of smoking, that they're also affected by that. So there's an argument for that smoking ban having a large impact on a wide range of people, and that's what public health is trying to do, and that's informed by epidemiology. Is the sort of the scientific discipline behind it. So it says here then that epidemiology is a quantitative discipline. So it involves itself in probability and statistics and having sound methodological underpinning for research. So as we get further into this video, you'll hear me talk about types of epidemiological study, and they need to be very rigorous in order to be able to claim causality, basically, or causation, I should say. So we'll get into the idea of, well, how do we come to learn that one particular thing might cause a disease? So, for example, I talked about smoking. How do we actually know that smoking causes disease? Well, we need to have a sound scientific methodology in order to claim that, because when that goes wrong, then we can be in big trouble. And again, I'll talk about that shortly. So this is a method of causal reasoning then. So we need to be able to actually have some sound scientific reasoning behind the cause of the disease that we're going to claim. We've already mentioned that this informs public health services. From our example with John Snow then, we can see that epidemiologists are concerned with the distribution of disease. So these days they use a systematic approach whereby they will count the number of cases or health events within a certain population. So they will look at, well, how many people in a particular area or a particular group of people. So it might, as I said, it might be a geographical location, or it might be a cross-section of a certain population in society. So, for example, if your research was looking specifically at black and minority ethnic groups, or it might be looking at a particular gender. So, to what extent are women affected by a particular health problem? And then they count the number of occurrences within that. They then need to look at where is that happening. So again, we've already talked about the idea of location. That can be a small location all the way through to globally, and the timing of it as well. So epidemiologists concern themselves with considering how that changes over time. So again, we're seeing a live version of this when we're tracking COVID-19 cases and deaths and hospital admissions live from day to day at the moment, and we're seeing that gradual, quite steady. We saw a gradual increase towards the end of summer and through autumn, and now we're seeing the beginning of what was referred to as an exponential increase as we see figures doubling fairly regularly. As we saw with our John Snow example, then that our counting of numbers isn't enough, that we then need to actually look at the proportion of that within an appropriate denominator. So we saw that John Snow used per 10,000 households, deaths per 10,000 households. What we're seeing in the media at the moment is the reporting of COVID-19 statistics per 100,000 people. And this allows us then to see the proportion of a disease within a given sort of set of a population. And as I've just mentioned, then we can examine how these change over time, or we might look at, well, how does that compare to 10 years ago? So, for example, obesity statistics, we might compare how many people are clinically obese in 2020 compared to 10 years ago, or compared to 10 years before that, and then we can see how that changes over time and try to attribute that to particular causes. So is that because we have more food available to us these days? Is it because the food that we're being sold is more nutrient dense? Do we have access to lower quality food? Is it because people are socioeconomically more stable as a rule, so we can afford to feed ourselves more? There can be many other factors as well, and that's what epidemiology tries to do, tries to account for the why, but we'll get to that shortly. With regard to the why, or what's referred to as causation, so that this is about, well, why is something happening? I just mentioned the idea of, well, why might obesity be more, why might more people be obese these days compared to 10 or 20 years ago? And we call that causation. Assigning causation is important for informing health interventions, because we need to know what causes a particular disease before we can do something about it. But we need to avoid certain confounding factors that can lead to us wrongly assigning causation in the presence of what we call correlation. So we're seeing two examples on the screen here then of wrongly applying causation based on correlation. Now, this example on the left then, people who drowned after falling out of a fishing boat correlates with marriage rate in Kentucky. Now, this is an intentionally sort of comedic, funny example of correlation, and how you can see at a glance that, well, those two things can't possibly be related. It's just coincidence, basically, that these things correlate when we put them on a graph. And if you were to Google sort of funny correlations or something like that, you'll be able to see lots of examples similar to this, where people plotted one thing against another, and they just happen to coincide with one another. And what we need to avoid in science then is wrongly interpreting correlation as causation. And we, on the right-hand side of the screen here, we're seeing where that has actually had a really severe detrimental effect. So this graph on the right comes from Wakefield 1999, and you can see that there's two references there from Wakefield. Andrew Wakefield was a British physician who in 1998 published a paper in the Lancet, and you can see the reference at the end of this video. And this particular paper has been retracted by the Lancet, because this is the paper through which he claims that there was a link between the MMR vaccine and an increasing incidence of autism in children. And what this graph is showing, although it's quite a difficult graph to read, actually, I've copied this straight from the BMJ website, and as you can see the references below, and unfortunately that's just the best quality I can get from this graph. But what this is claiming then is that at the introduction of the MMR vaccine, we've then seen an increase in the number of diagnoses of children with autism. And so you can imagine then that because of this, now this is wrong. This is being disproved by many other scientists, and that's why these papers have been retracted. And as a result of his work, Andrew Wakefield was, I believe, removed from the British Register for doctors. He was removed from the GMC as a result of his sort of incorrect hypotheses here, and it was actually proved that they published misleading information intentionally based on a few confounding factors. So funding that they didn't disclose, and other conflicts of interest that they didn't disclose. They also were guilty of potentially cherry picking their results. So they used a very small sample size, and they intentionally chose children that were going to demonstrate the point that they wanted to make, because they actually intended on trying to demonstrate a link between the MMR vaccine and autism. Whereas, as I said, that's been since completely disproven, but it's had this huge impact on vaccination levels in children. So at the time, we saw a dip in people taking up MMR vaccines for their children, and it's been an important sort of push for the anti-vaccination movement that we've seen ever since, which again is very damaging for public health, because public health is concerned with vaccination strategies, and it's obviously going to be damaging for those individuals who don't receive important vaccinations. So yeah, just to kind of reiterate, this work has been retracted and disproven, and we just need to be careful that we're not wrongly assigning causation based on correlation. And this Wakefield work actually is a really good example of that. Here we see that epidemiology comes in different types. We can see it as either descriptive or analytic epidemiology, and they have different purposes. So our descriptive epidemiology is concerned with answering these key questions of what, who, when, and where, and I'll explain more about those in a moment or two, whereas analytic epidemiology is more concerned with actually why is this happening, or what's the mechanism of a particular cause. So we can get into that on the next slide. Descriptive epidemiology has these 5 W's that the what, who, where, when, and well, you said why or how. Actually, we've assigned that to analytic epidemiology. So we'll get more into that in a moment or two. So the what is the health issue of concern. So is that a communicable disease? Is it I mentioned before this idea of road traffic collisions? Are people dying in them because for some reason they're not wearing their seatbelts, or do people not have access to the right PPE at work? So who's being affected by that? We've already kind of mentioned some of these ideas of, is it a particular gender? Is it a particular ethnicity? Is it a particular age group? And where are they being affected by these? So is it a particular population geographically, so a region? Are people being affected by it in the workplace? Are people being affected by it generally sort of throughout the population of the country? And is it any particular time? So that might be seasonal, for example, seasonal flu. So we understand that people are more likely to be affected by respiratory viruses through the colder winter months. So we've got seasonal cold and influenza viruses. But there's other seasonal things as well that affect people. For example, hay fever. We know that people are more likely to suffer from seasonal rhinitis during the spring and summer months when there's more pollen in the atmosphere. But then, rather than these sort of more simple terms, what we're seeing here then is that we can refer to the what as the case definition. So we define, well, what is a case? So again, sort of thinking about the sort of contemporary example with COVID-19, we see the reporting of case fatality rates. So that's the number of people that die per case of COVID-19, or the WHO. So we've already mentioned population there, and we use the term population. That can be generalized or specific groups. We refer to the where as the location. We've already mentioned that a few times. When is obviously the timing, and then we're going to get onto causes and risk factors shortly. Within descriptive epidemiology, then there's a couple of key terms. I've tried my best to avoid using these as I've been talking, but I think I've said prevalence and incidence a couple of times now, so we need to define what we mean by this. So prevalence then is the number of existing cases of a disease within a particular population during a defined period. So what we mean by that then is, so say for example, in one particular year, how many people have a particular disease, such as, I'm going to stick with diabetes because I keep using that as an example, and I know that's on the slides coming up. So how many people have a pre-existing diagnosis of diabetes within a particular period? So that's going to include people who have diabetes in 2017. They're going to contribute to the prevalence statistics of that year. Then they will still have diabetes in 2018, so they'll contribute to the prevalence statistics in that year as well, because that's just something that's ongoing. And when we contrast that with incidence, what we mean by that is the number of new cases. So that's if the person is diagnosed with diabetes in 2017, they'll contribute to the incidence statistics of 2017. However, then when we tick over to 2018, they'll contribute to the prevalence statistics, because then that's not a new case, that's just someone who is already diagnosed with diabetes. Then we can see this example here then as these are tracked on a chart. Now I'm looking at my diagram here, and this is poorly presented, I apologise for that. So what this is actually showing is the prevalence of diabetes in particular age groups. So we're seeing that it is more prevalent in the older age groups. So once we get to the 50 pluses, it's then starting to be pretty high, and then it's tailing off. So this is useful then for assessing the burden of disease by understanding, well, what proportion of people across a population have a particular disease. So then we understand, well, what do we need in order to care for those people? Like what systems and healthcare structures need to be in place in order to support those people with diabetes. So it's valuable for planning from one year to the next, because unless these people recover, and that's very unlikely with a chronic illness such as diabetes, so people either recover or unfortunately sometimes people die. But other than that, they're going to carry on from one year to the next, and they'll continue to need care. So it's very useful for planning healthcare systems. Not so useful for determining what caused the disease. We can just kind of describe how many people have a particular disease, but this doesn't help us to understand what caused it in the first place. For that we need our analytic epidemiology. Incidence then. So here we can see our, again, I apologize, this is another quite poor graph, because we've got prevalence and incidence traced together, and these are American statistics, and they show a different scale for prevalence on the right than for incidence on the left, which makes it a little confusing to look at. But we're trying to look at the pink line then that shows the number of new cases of diabetes increasing from one year to the next, from 1980 all the way through to 2008, which is when we then actually see a change, when we see a decreasing in the number of new onset diabetes cases from 2008. So what we know about incidence then, as I said before, this is about new diagnoses of disease. So in high incidence represents diseases with a high occurrence, and obviously if it's a low incidence, then it's got a low occurrence. That's not necessarily to say that that's not important, because sometimes we can have quite a low incidence of a disease, but if we know that that's really likely to have a huge health impact on people, then that needs to be addressed, even if it's quite a low incidence. This can be used to help determine the cause of disease, because once we know which people are getting a new onset of a disease, we can start to understand, well, what separates them from the rest of the population. So what makes them unique and therefore more likely to develop a particular disease. So with diabetes in mind still, we can look at, well, these are the people who've developed diabetes recently, and what things do they have in common as a group? So for example, we know that being obese makes you more likely to develop type 2 diabetes. Certain dietary factors are going to make you predisposed to being obese. There might be some genetic predisposition there as well. So as I said, from this data, we can start to understand what makes people more likely to develop a particular disease. And therefore we understand what's the likelihood of people actually developing the disease in the first place. Now we get on to analytic epidemiology. So this is used to investigate and identify the cause of disease. And again, I put this in inverted commas because this isn't just about disease. It might be identifying what causes people to make particular decisions about their health or risk factors. So what might make people more likely to have an accident at work, for example. So that's not just about disease. The epidemiology tends to just kind of bunch it all together as disease. So So this is about testing specific hypothesis then. So analytic epidemiology is about developing a hypothesis based on the scientific information that is available. And by hypothesis, we mean that's a statement that makes a claim based on the data that we have. So we tend to see hypotheses coming from deductive forms of reasoning. So by the process of deduction then is about gathering a broad set of data. So for example, we might look at, we're going to stick with smoking as an example. We're going to look at people who smoke, and we're going to hypothesize that smoking increases your risk of certain diseases such as cardiovascular disease and lung cancer. So we start to gather data based on people who smoke. So we look at how many people smoke go on to develop these diseases, and are there any other factors at play that might be the cause rather than smoking. So we gather this kind of broad data set, but from it we start to then narrow down our focus to a particular hypothesis, which is this statement of, for example, you have an increased risk of developing lung cancer if you smoke tobacco. So that is a hypothesis based on the scientific evidence. And these studies typically involve cohort studies or case-controlled studies, but we'll get onto those in a minute or two. So analytical studies then, they can be either experimental or observational. The difference between the two then is that an observational study it does just that. It observes certain populations. It doesn't actually experiment on them. It literally just collects data from them. So for example, it mentions here a cross-sectional study. So what that means is that at a particular time, we gather data from a population. So that might be a particular group within a society, or the society as a whole, and that allows us to just get like a snapshot, or literally what it says, which is a cross section. So we're getting this snapshot, a cross section of society at one particular time. So then you can survey how many people have a particular disease, how many people across the population smoke, or how many people have diabetes, how many people are obese. And that starts to give us just this sort of broad data set, and from it you can start to look at, what do these certain people have in common? So if we know what somebody does for their occupation, and we know that they're obese, then we can start to see, well, is there some commonality between people who are obese and the work that they do? So do people become obese because they do a very sedentary job? But as part of our cross-sectional study, we might also ask about diet and exercise as well. So are people becoming obese because of particular dietary choices, or because of they don't have access to physical education, for example? A longitudinal study, rather than taking that kind of snapshot, will actually gather data from people over a longer period of time. So that's what it means by longitudinal. So we're looking over a long period of time and gathering data across that sort of time frame in a similar way, so then we can kind of use that data to look for that similarity between different groups, and start to think about what might be the cause of a particular illness. And then we have experimental trials. So your typical one here then is your randomized controlled trials. That's seen as like the gold standard of medical trials, where we have a group of people are recruited to a study, and they should all have similarities, so that then we can assign some people to what's referred to as a control group. So those people will have either kind of not normal care or no specific intervention whatsoever, and then the study group usually undergoes some sort of intervention. And the idea of randomization then is that we don't specifically choose which group a person's going to be entered into on a trial, that it should be done at random. And so we have this idea of the control group. So then we can measure, well, what happens if we do nothing, or what happens if we just do our normal thing? So for example, if we have a new cardiovascular drug that's aiming to reduce hypertension, so So we use in our control group, they might just receive the normal, whatever the standard treatment for hypertension is, so something like Ramipril maybe, and then the study group will receive the new drug, and we test, well, what is the actual effect of that new drug when compared to the standard treatment. And this gets us to the end of this video then. The only remaining slide are the references, and you can take a look at that in your own time. Thank you very much for listening. Hopefully this now has allowed you to understand what epidemiology is, what some of the underlying principles are. I think it's an enormous discipline, so hopefully I've done my best to sort of give you a bit of an introduction to some of its founding principles. The second video is then going to look more closely at COVID-19 and kind of tracking that from the end of 2019 when the virus was first discovered through to March the 23rd in the UK, which was when we first went into our lockdown, and trying to kind of unpick what was happening internationally and what was happening more locally, and that's going to inform some in-class discussion. So thank you very much for listening, and I'll speak to you soon.